Synovial fluid. That was when we talked about the how muzzle pull occurs. Muzzle pull. I think I even gave you an assignment that read about it on how muzzle pull occurs, right?
Yes, sir.
All right. So who is talking for us to hear? Who has done it? Oh, before I mention the names, I have your names here. So who is starting it for us? Anyone at all can start for us.
Something I can share if
Please,
I
before
have
you talk,
something that I want to
raise
share.
your hand up. Before you talk, raise your hand up. Okay. Let's see your hand, then I call you. Madam Christiana
Yes,
Afana.
sir.
Christiana Afanam.
Yes, please. Good afternoon, doctor. Good afternoon, colleagues.
Good afternoon.
Okay, so the little research I did, I realized when there's an overstretch to the muzzle, depending on where it is located, it feels a shock. And as a result, there will be pain. Pain will be triggered in there. That's the little research I did, and that's my understanding of muzzle pull. Thank you.
All right. Thank you. Yes. Any other? Mr. Henry N.K. Quay.
Yes, sir. So this is what I also had as per the muzzle pull. There is a strain that is injured to the muzzle fibers, and then or the muzzle tendon, and it's often near the myotendinous junction. In the mild cases, it involves overstretching, whilst more severe cases involve the partial or complete tearing. So the typical setup and why it happens during specific movements is that most strains occur when the muscle is forced to lengthen while contracting, such as eccentric loading, or is exposed to a high force at long length tension disadvantage. And this is why hamstrings, groin, and calf strains are common in sprinting, kicking, sudden deceleration, or change of direction task. So the first mechanical failure, that is the sarcomeres, give uniformly. Please, can I go on?
Yes, I'm listening.
And so it's inside the muscle fiber, force is generated by sarcomeres, that's
Yes.
the actin myosin contractile unit. And during high load eccentric work, some sarcomeres overstretch more than others. And this is what we call the non-uniformity, and can be pulled beyond optimal filament overlap, popped sarcomeres, disrupting force transmission. So what fails first? The microstructure. So first, the myofibrillar disruption, contractile protein stroke or architecture, and then the cytoskeletal protein strain, for example, the chitin associated structures, and then the membrane or sarcolemma perturbation, then increased permeability. Then have the biochemical cascade, that's the calcium dysregulation plus excitation, which gives the contraction uncoupling. So the membranes and contractile structures are disrupted. One, calcium homeostasis is disturbed. That is, the calcium handling becomes abnormal. Excitation, contraction coupling is impaired. And then you have the photolytic pathways and inflammatory signaling ramp up result, acute strength loss and impaired contraction, even before significant swelling appears. Then have the tear level injury, micro tears to the hematoma, hematoma, that's in bigger strains. If
All right,
enough fibers,
all right. It's okay. I get you. I mean,
mm,
I've seen the line of your. I mean, where how do you call it,
where
your
I'm
research?
coming from.
Yes,
Okay,
you are making us know about the physiological. I mean, makeup. What really happens
happy,
when we are talking about the muscle pull in terms of
yeah,
the physiology.
that is it.
What is really taking place? If you talk about calcium influx, if you talk about myofibers, it means that you're talking about how do you call it, physiology of the muscle. That one is fine.
Yes.
That one is fine. I get it. We are focusing on the biochemistry aspect.
Aha. So I'm looking at uh,
I mean, you are right. You are right. I get you.
I
You are
mean
right.
the biochemical aspect. Okay, what we are talking about the calcium homeostasis, which is the step.
Okay. Okay.
It says that is the step. So that is the biochemical aspect,
Biochemical
and
aspect.
then the excitation, the contraction coupling, which is impaired, and then the proteolytic pathways and inflammatory signaling ramp up result, which gives the acute strength loss and then the impaired contraction, even before the significant swelling appears. So that is the biochemical aspect of the whole thing.
Okay, thank you for your research. At least you've made us know that you did your research. Any other person?
Yes,
Thank you,
please.
sir.
Who is there? Who is there?
Ingrid.
Is it Madam Ingrid, right?
Yes, thank you so much. Good evening, good afternoon,
Yes.
colleagues. Yes. Yes, so with my research, I found that a muscle pull, the chemistry involved in it is when the body goes into it experiencing hypoxia. And what hypoxia is when there's lack of oxygen that goes to the muscle. The muscle needs the oxygen, and in fact, extra oxygen when it is under added stress. And so when it doesn't get that oxygen, that's what it goes into like a muscle fatigue. It starts cramping, and that is because of it not being able to to have that assistance with the oxygen. So it goes into like what they call anaerobic metabolism, where it is trying to produce energy without oxygen. And that is highly stressful on the body. And that is why it goes into that spasm and cramp. You feel that pain. I could go into more of it as well, that what happens. There are causes of that, of course, the lack of oxygen, which are several. But the main thing in terms of the chemical causation of the muscle cramp is hypoxia, which is a lack of oxygen that goes to the muscle.
Thank you very much. Yes. Any other? Mr. Emmanuel.
Hello, sir. Yes, sir. Okay,
Yeah.
so surprisingly, I have almost the same research with Ingrid. Uh, Mine is basically also about the hypoxia, which is the oxygen deprivation. So let me say there's a metabolic shift from having a lot of oxygen, which is aerobic, to anaerobic when you are doing an activity. So because your body now needs that form of energy, there are about three main energy consumers in your system that will be trying to also fight for ATP. Once they are trying to fight for this ATP, it leads to the depletion of this particular oxygen that is within the muscle. And basically, the oxidative stress will take in. So once there is oxygen deprivation, then it will lead to the tear of the muscle. So basically, just to add up to what Adam Ingrid said. Thank you, sir.
You are right. I mean, you are right. You are right. You are right. You are right. All right. So that's good. So that is what I really wanted. I mean, for Mr. Kent's own is more of physiology. Uh-huh. But we're talking about the biochemistry aspect. When we talk about the biochemistry, like I was saying the last time, basically the reason why it happens, it doesn't happen in a normal person who is walking, but someone who is sprinting, someone who is running, an athlete. It's as a result of the hypoxia at the molecular or at the biochemical level. There is what oxygen needed for what for the production of ATP, production of ATP, or for the process of glycolysis to occur to produce ATP. And now this ATP has to enter into the mitochondria to undergo what we call Krebs cycle to produce higher form of ATP, which is around 38 amount of ATP. Now, then what happens is that in a state of hypoxia, as she said, it changes from aerobic to an anaerobic state. And as it continues for a long time, it builds up what we call the lactate. If the lactate continues to build up, it becomes acidic, forming lactic acidosis. The lactic acidosis is what brings about the pain, the pain that the patient feels. A buildup of the lactic acidosis of the lactic acid forms lactic acidosis, and that is what brings about the pain. And it's all because of the fact that there is a state of what hypoxia. There's a state of what oxygen reduction. There's a state of what stress in oxygen production. Do you understand? So that is basically about that. Mr. Mevoji, is your hand up?
Yes, please.
All right, let's have you.
My research also reveals that there are some other causes. For example, we have muscle symptoms that can arise from drug toxicity. For example, statins, endocrine disorders, example, thyroid diseases,
Okay.
infections, and chronic pain syndromes like fibromyalgia. Thank you.
Okay, that's fine. So muscle pull mostly we are saying that mostly occurs in athletes, but it doesn't mean that it doesn't occur in normal people. And so for the normal people, it would be that a particular condition, a particular medication, a particular lifestyle, a particular positioning can cause muscle pull. Do you understand? So that is where this one comes in. But when we are talking about the athletes, someone who is running, and it's very common in them. You see that someone on a heavy, let's say 200-meter race or 300-meter or 100-meter race, then someone is struck down or one leg is pulling the person has to stop over, or even they have to even help the person to finish the race. That is what we are talking about here. Yeah. All right. So thank you for your research that you've done. Those of us who did the research, well done. Those of us who didn't do it too, please try and be doing the assignments, because my class is always a practical one. I wouldn't bring anything from anywhere. It will be all that we are discussing, what we are talking about, what we have been discussing. How does muscle pull occur? Then it will be there. Discuss how muscle pull occurs. And I'll be looking out for some major points. Some keywords: hypoxia, anaerobic states, lactic acidosis, or lactic formation. Some of these words should come in, and you get your marks. Do you understand? Okay, let me take the last question, then I start. And I want Lumide, let's have you.
Yes, good morning and thank you.
Good morning.
What is the relationship between all of this and when divers go deep and they get what is called the bends? Is that the same phenomena that's happening?
When divers go deep and they get bends,
Yes. Is that the same kind of cramping or muscle? Is that what is happening there, please?
yes.
Okay.
Does anybody want to answer before I come in?
Oh, okay. My little knowledge of that is that it is different in the sense that I think it's nitrogen that there's an excess of nitrogen that forms in the body as the in the blood as the diver goes deeper and deeper. Perhaps because of lack of oxygen as well, but I think it is a different thing because it involves the pulmonary side, which could be related. But anyway, let me stop there.
Okay,
But
so
I think
she has given us another assignment, but let me just give you a better eye view of it. So what happened is that at that point when they dive down, there's how do you call it? Their breathing becomes a problem. Fine. What happened is that they're able to. I think they give them how do you call it? Oxygen supply, but then sometimes the inhalation goes inward, but then the exhalation, breathing out the carbon dioxide, sometimes it is not enough. Do you understand? So there's a buildup of CO2. This CO2 converts to COH. Maybe I'll have to do more research on it. Let's all go and do research on it. But then it's mostly as a result of what? The exhalation. That is what gives them a problem because most of them they carry these divers, except the person did not carry. Are you talking about those who carry the oxygen along? Because there are some who carry oxygen tanks along. Madam Olumide.
Yes, even those who carry oxygen, sometimes they get that cramp and they have to be pulled up. I live on the coast, so it happens quite a bit, right? So I'm trying to understand it. Yes, especially those who do not go down with oxygen, though. They have to come up quickly, right?
Yes. So the reason being is that you see, fine, those who go up with the oxygen, it gives them. But then I don't know. It can be that when it gets to a point where there is a reduction, that is when there's a reduction in the level. Some of them they tend to how do you call it?
Okay,
Exhaust the amount of oxygen. Yes.
yes, I was just going to say thank you. With this insight from this discussion, I'm going to be doing additional research so that I can understand it more.
That's
Thank you
that's
so much.
that's right. But we all need
Yeah.
to also research as well. It's also another one for us. Then
yes,
it also brings us to how about those who also go into space? That one too is there. That one too. There's also as the altitude goes higher, there is oxygen deprivation at the higher altitude. We know that one too.
Exactly, exactly.
Yes, there's oxygen deprivation at the higher altitude too, and so they also feel the same. You understand?
Yes. Okay.
Yeah.
Thank you
So
so much.
we have another research to do for next week. Now let's move. Oh, why do you beg? We are all going to learn. I'm also going to learn. Why do you beg? You beg for what? We are all learning it. Oh, hello. Do you think I also don't learn? I also learn. Oh, hello. We are all learning. We are all working and learning. So it's. I just come and explain this to you. We are all learning and working. So it's all about we beg. It will beg in one and inquire. Who should go and do it?
in fact, may I say something, please? Um, it is important to understand, especially for coastal places like Ghana, although I know they don't really do deep diving much in Ghana. However, it is a different concept, and it's important to understand that because it has to do with nitrogen being absorbed into the bloodstream.
Okay.
And the lower you go, it actually kills you very quickly, whether you have oxygen or not. It has nothing to do with that. It has to do with the depth of the ocean when you go down and how fast. So you have to go down slowly. So, but it's a good research. Thank you.
Okay. That's a nice one. We are all new to this one. So we all need to go and research on it. All right, so let's
Sir, please,
continue.
my hand was up.
Mr. Ambrose, I can see your hand up.
Yes, sir. Yes, please. Sir, there's this thing I just wanted to pass it across. When you talked about the space thing, I don't know, for all these years, we've known people going to the space and all that, but currently, the new research and the new updates that are coming shows that nobody has ever gone to that space that they are going. But the space we are talking about is on this earth, and then it's a bigger space somewhere, not in the skies. The space they go or they've gone has never been the sky. They're up there because there's this firmament covering the skies that nobody has ever gone beyond the firmaments. So this place we are talking about is somewhere behind Antarctica. There are new discoveries that are coming that nobody has exceeded the skies, which is above the firmaments. It is scientific, it is biblical. And now new discoveries are coming out. And when you talk about space, it is a bigger space somewhere behind Antarctica on this same Earth land, not space in the sky. Thank you.
Okay, that's fine. But you see, it's true. What you're saying is true because the one we see here, it goes deeper, deeper, deeper. I mean, with studies, archaeological studies, the skies we see it like that. But I mean, for you to even go to the level where the plane can reach, it's even higher. You get what I'm saying?
Yes, please.
Yeah, it's even very high. It's even very high to give you that oxidative stress or to give you that level of how do you call it, hypoxia that can occur. Yes. So I mean, like she's saying, how do you call it? The divers having difficulty breathing with the divers. It is part of the. I mean, one, the nitrogen is part, but then because they are being supplied with the oxygen, their exhalation becomes a problem. So CO2 buildup also causes that. You understand? CO2 buildup. I mean, carbon dioxide because they have to inhale and exhale. Madam Oyumide, right? They have to inhale and exhale. But then sometimes the exhalation becomes a problem because as they go down, it's a very short exhalation. Then in order to then the inhalation is more and the exhalation is lesser. So the buildup also causes that problem to us. But we'll still have to research. We'll all go and research on that. Let's look at the peritoneal. We looked at synovial fluid. We looked at how do you call it? What's the name? Oh, what is it? We looked at CSF, cerebrospinal fluid. This one. Then we looked at synovial fluid at the joints. Then we talked about the fact that we are looking out for the what? Hydrogen, lactic hydrogenase is usually raised in conditions like what? Arthritis. That is the lactic dehydrogenase is what brought about the lactic acid and the muscle pull something. We also talked about uric acid in joints, and it's very common in conditions like what? Gout. Higher uric acids, conditions like gout, it brings about condition we call gout. Yes, I think I even asked you to read our gout, so let that one be in mind. One day we'll ask about it. Then we looked at peritoneal ascites. Then I made you know that it can be that there's what? That is this one I talked about edema. Do you remember? I explained something about edema, whether it's as a result of what? The pressures. I talked about how edemas are formed. And we said that it can be that it is as a result of an edema that is forming, or there is what? An inflammation, and there is what? A secretion of what? Of pus. Do you remember that? Yes, we talked about the fact that if it's a transudate or an exudate, transudate is what? When there is an edema formation, an imbalance in pressure within the blood vessels due to what? Conditions like liver disease. Or when there's an exudate, there's an inflammation that can cause this one. Talked about what? Abdominal paracentesis. We are saying that there's a procedure that is done to relieve the pressure so that the patient can what? Can breathe in very well. What happens is that when there's a pressure in the abdomen, it presses against the diaphragm. and it makes breathing very difficult for them. Yes, and sometimes the condition or the state will not kill the person, but the state of what? Hypoxia, the state of what? Difficulty breathing. The state of dyspnea is not hypoxia. The state of dyspnea can cause what? Dyspnea is what? Difficulty breathing, right? Shortness of breath. That is dyspnea. The state of dyspnea will cause that, and the intra-abdominal pressure from this fluid is just going to cause the pressure. So we do this to relieve the pressure and also to make the patient feel comfortable. Yeah, this one is conservative because normally when they get these conditions, you do conservative management so they find their way out. Obviously, there can be extensive treatment, liver transplant, and all those ones. Particularly if it's a liver disease, they do liver transplant for them. Then the liver takes up everything. But then in Ghana, where liver transplant is very difficult, organ transplant is very difficult to do. Most of our cases tend to lose their lives. Now, with the peritoneal fluid, we said that we are looking out for the albumin level. The most important biochemistry test to perform for peritoneal fluid analysis is albumin, in order to differentiate between transudate or exudate. Now we are saying that albumin levels make us to know whether it's a transudate or an exudate. Why do we say that? Because when the albumin levels are low, that is when we get to know whether it is a transudate or an exudate. When it's a transudate, what does albumin do? Albumin functions to help with what? Maintaining oncotic and hydrostatic pressure. So the albumin is focusing about the imbalance. The albumin levels talks about the imbalance. When we realize that there's low in albumin level, then we get to know that okay, then maybe it's from what? It's as a result of what? A transudate cause. So the difference will evaluate serum ascites albumin gradient, that is SAAG, to determine the occurrence of transudate or exudate condition inside the abdominal cavity. So the albumin levels will make us know whether it's a transudate or an exudate. And I've explained to you the transudate and exudate. Trans means it's coming from somewhere, and exudate means it is emitting from itself. So peritoneal cavity, these are the values. So the albumin level 1.1 is considered evidence of a transudate condition. Level of total protein will be low, less than 30 grams per liter. When there's an exudate, is the value of albumin level, serum ascites albumin gradient below 1.1 gram per deciliter, considered evidence of what? Occurrence of what? Exudate. So when it's above 1.1, we say there's what? It's a transudate, and when it's below 1.1, this one you are going to use it. I mean, you meet it when as the need be for you to request it. But then you just need to know that the ascites that is formed, I want you to know, the ascites that is formed, if someone's belly is distended, it's either is a transudate or an exudate. If it's an exudate, it means that if it's an exudate, it means there's an inflammation. When we say exudate, it's like something that is discharging, like you having a boil and the boil is discharging. We say there's an exudate from the boil. Like you having a tonsil and we say the tonsil is discharging. We say there's what? Peritonsillar abscess with what? With an exudate. So anything that is as a result of what? An inflammation that is occurring or an infection, you have a boil, you're able to spill some blood out of it. That blood coming out of it is what? It's an exudate, or yes, you can say leakage or whatever, but then it's an exudate, it's leaking out of it. Then, if it's what? A transudate, we say there's what? When there's an imbalance in blood vessels, and that mostly results in what? In edema formation. So we can also check the glucose. For normal patient, glucose value should almost be equal to the blood glucose value. However, in infection, others occur. However, if infection does occur, peritoneal fluid glucose value will be lower than the glycolytic activities of the bacteria or white cells. So we are saying that if there's an infection cause, the glucose level becomes lower than that of the blood level, meaning that there are some organisms that are what? That are feeding on the glucose. Do you understand? Do you understand? Let me see your thumbs up if you understand. All right. Now we look at Ms. Apia, you have a question?
No, sir.
All right, let's continue. So now look at pleural fluid. So we are looking at the fluids in the body. I told you that we are looking at fluids. We have looked at the CSF, cerebrospinal fluid. We have looked at the synovial fluid that is found in our joints, all our joints. We have looked at peritoneal fluid that is found in the abdomen. Then we are also looking at what? Pleural fluid. You understand? Yes. There are some people, the abdominal distension you see is not only fat, oh, fluid is fat. Some people you see that the abdomen is distended, not only fat, some of them fluid is fat. That's what we are talking about here, but just that it hasn't gotten to a state where it's going to give them that shortness of breath. So they are working fine. Now we look at what? Pleural fluid. In the chest too, there are situations whereby there's going to be what? Pleural fluid, what we call the pleural effusion. Pleural effusion. This is what we call the pleural effusion. You see fluid in the pleural space. You see the fluid there. So you go and do an X-ray. Okay, let me show you an X-ray. That is very common. You see, let me show you an X-ray of a pleural effusion. Give me 1 second. Give me 1 second. Pleural effusion. Yeah, so you see, so this is what? This is a pleural effusion. This very one. So this is an X-ray of what? Of a pleural effusion. So you see, this is the level of the what? This will be the total level of the what? Of the lungs. But if you see this area, it's all fluid. This is what? This is a clear example of what? So if you see an X-ray and you see this, anytime you see something white, it's either on the X-ray, ideally the X-ray should be what? It should be air. I'm saying the lung should be what? Should be aerated. It should be, all these parts should be air. Air is seen as dark on X-ray. Then fluid and what? And bones are seen as white. Okay. Fluids are more whiter. So you see this is a fluid. And these ones are bones. The bones are like gray, they are like ash, but the fluids are like pure, like white. You understand? Or fluids or organs are seen as white. So you see, this is fluid. Yeah. I don't know. I think my money is on my phone. I don't have money. I don't have physical cash. So this is these are classical examples of what of pleural effusion. Ideally, you should be able to see the cardiophrenic and the you should be able to see the borders of the how do you call it, of the lungs and that of the heart That is the cardiophrenic angle and the what costophrenic angle. But then in fluid, you see that the angles are obliterated. Let me put it this way. I'm coming. So look at this. So you see this one. You see this one. You see this is what? This is the cardiophrenic angle. This angle. You're able to see this angle. You're able to see the borders of the heart and that of the borders of the heart, of the how do you call, of the lungs. But then when there is a fluid, you can't see this part. So this part cannot be seen. No. The lung is there. You see all these ways are the lung parenchyma. But then this part is covered by fluid. You see the effusion. It has been covered by fluid. So this is what? A pleural effusion. And normally, pleural effusion, so let's say pleural effusion is accumulation of what? A large amount of free fluid in the pleural space. It is the same as edema fluid in the tissue and can be called edema of the fluid. You understand? So just like we can have edema occurring in the abdomen, we can have the same thing occurring in the what? In the chest. So more like edema of the chest. Yes. Oh, that's fine. So the drugs are finished.
That's what he said.
I will take it.
Just buy another one.
Which one does he take?
He doesn't.
What is he? Where is the slide I was reading to you? Yeah, so we're saying that what are the causes? One, blockage of lymphatic drainage from the pleural cavity. So you have this one in your slide, eh? When there is cardiac failure, when there is greatly reduced plasma colloid osmotic pressure, when there is infection, inflammation of the pleural surface is causing leakage into the pleural cavity. So you realize that this one is going to be what? If it's from an infection or an inflammation, it's going to be what? What is it going to be? Is it going to be an exudate or a transudate? Yeah, Ms. Zara too.
Exudate.
That's right. Then one is what? When there's a blockage of what? Is a lymphatic drainage from the pleural cavity. And when there is what? Greatly reduced osmotic colloid, plasma colloid osmotic pressure. That one can be what? That one is as a result of, and even the cardiac failure is from what? From a transudate cause. The rest are from, but then the infection and inflammation is from what? It's from an exudate cause. Do you understand? Alain, I have one client I have to see, so give me some few minutes. You can be going through the slides while I sort them out and we wait for you right now. Give me some few minutes. Let me join you right away.
Sharp.
Mr. Champon, Eric, is your hand up? Is there a hand up? Is there a hand up? So you see this one. This is what? Massive pleural effusion, bilateral. It's occurring on both sides. And this one, and pleural effusion too. There are multiple causes. It can either be what? From a trauma. Somebody is involved in an accident. Somebody has been stabbed. You understand? All those ones will occur as a result of what? Blood leaking from somewhere. So it's either as an exudate or a transudate. So when we say the exudate or transudate is a bigger classification. Now, when you want to come down to the causes, when you come to the exudate, then we'll say that okay, there's what? Maybe there's a long time, how do you call it? Lung infection. Maybe there's a pneumonia. There is what? A bronchopneumonia. There is what are the bronchiectasis, infections of the heart, of the lungs. Then we come to the under the transudate to when there's a trauma, when there is a how do you call it? A piercing, yes. When there's an accident, somebody can get hurt and be having a fusion of edema forming inside the what? Inside the chest. Just bear in mind as this. I'm saying that the mere fact that you can get hurt and your feet will swell, the same thing is what is happening in the chest. If you understand it that way, you'll be able to appreciate what I'm talking about. You understand? So this is what this is also happening from what? From a trauma. A trauma can cause it. Can cause this. We call this massive what? Pleural effusion. You see, it's affecting. It's covering up to this level, and even this level too is covering some parts of this level. Bilateral pleural effusion. So these are some examples of what? These are some examples of pleural effusion. Let me paste this one in your slide. So are we okay? Is there any question? It's an issue of what? Of a pleural effusion. Olumide, Mr. Emmanuel, and let's have you, Madam Olumide.
Yes, sir. Thank you. I have known of patients with breast cancer who have this water in the lungs, and then it has had to be drained post the mastectomy. I just wanted to comment on that, you know.
Okay, so there
Yes.
can be malignant cause for what? For the effusion. Such that there's a malignancy or a cancer of the lung or a cancer of the breast, that is what? That has infiltrated into the lungs. And that one too can cause an effusion. So that's what I'm saying that, and that one will be of what? Of an exudate form, because there's an infection. And that as a result of that, there is what? Fluid that is seeping into the what? Into the uh, pleural space.
Into the cavity?
Exactly.
Okay. Okay.
And that one can cause
Um,
that. It has, we
okay.
say it's malignant. It has, it's a malign cancer. When the cancer is malignant, it spreads. You understand? That is why breast cancer becomes one of the dangerous or serious or deadly fatal cancers because it happens and it spreads. It spreads into into the lungs, affect the heart. You understand? It is spreading. So areas of the
Yeah.
chest, organs around the breast are going to be affected. That is why they die very early.
Okay.
You understand?
Thank you.
Yeah.
Thank you.
Yeah. Mr. Echampon and Mr. Diodu, let's answer your question. We are still on this slide. Let's hurry up.
Hello, sir.
Yeah.
Good afternoon.
Yes, sir.
Sir, thank you so much. Unfortunately, I've missed your class a lot because I normally goes to church. I'm a bishop general overseer. I will come late, and even I'm so it pains me a lot because I love the way you are explaining things and you are just teaching. But I hope that I will cut it out. So please, when I come, you are just talking about CSM, spirogina meningitis fluid. And I just wanted to explain that part from you because I did not understand it.
CSF is cerebrospinal fluid.
Yeah. So what's the causes of that?
So cerebrospinal fluid is okay. Let me give you a brief. I mean, cerebrospinal fluid is it is the fluid that lines the brain. That one is not a problem. That is a fluid. That is a protective barrier or a protective tissue for the what? For the brain. It protects the brain, and is the how do you call it? I'll say they are it's a messenger to the brain. If the blood from the body, all parts of the body gets to the brain, it assimilates into the cerebrospinal fluid. For nutrients, oxygen, and everything, it is the cerebrospinal fluid that feeds the brain. So
Okay.
if you want to check any problem in the brain, we normally do a lumbar puncture to aspirate the cerebrospinal fluid. Did I give you a picture of lumbar puncture? Did I give you a picture of lumbar puncture?
No, I haven't come across
Those
it.
who were in class, I think I showed you a picture, right? Mr. Apia?
Yes, sir. Sir, will show us.
Maybe we have to put some pictures in it so that you appreciate whatever I talked about. Because I remember I showed you a lumbar puncture, but I didn't put it in your slide. That was unfortunate.
Okay.
So we normally do a lumbar puncture. A lumbar puncture to do what? To get the what? The cerebrospinal fluid. And now we'll take the cerebrospinal fluid to the lab to go and look for what the problem is. And normally we said that in conditions like meningitis, normally we check for the what? We check for the glucose level and what? And what again do we check for? We check for the protein levels. Do you remember?
Yeah, I remember that.
Yeah, we check for the glucose level and the protein levels. Give me 1 second. What? One morning, one evening. Oh, really? It's not where?
The prescription that was sent to me.
You didn't find.
500 milligram Borax, 80 days. That's one. So I dispensed 80 days, then we sent 100.
So you dispense another one. You dispense another one. Dispense it for BD. Yeah, so they normally take a lumbar puncture to, let me put it here so that you see. Yeah, so that's a lumbar puncture. You see the slide? And that's what we are doing. We are going to take what? The cerebrospinal fluid. When we take the cerebrospinal fluid, what are we looking out for? We are looking out for what? The protein levels and the glucose levels. Now we are saying that when the protein level, when the glucose levels are what? Are low. Or yes, okay, let's use the protein. We're saying that when there's elevated protein values, it suggests that there is what? The blood-brain barrier has been broken, and so the person might be suffering from what? Meningitis, hemorrhage, or multiple sclerosis. That is when we find protein in the CSF. Ideally, there should be a volume of there should be a threshold. But then if you realize that there's a high level of protein, it means that the blood-brain barrier. When we say the blood-brain barrier, we are saying that it is a shield, or it's a barrier that prevents toxins and larger molecules, any foreign organism from entering the brain. So that is when we say blood-brain barrier, it's like a barrier. It's a semi-permeable barrier that prevents microorganisms or toxins or unwanted particles from entering into the brain. But then if you realize that there is high level of protein there, is for instance, let's say Ghana has borders. Let's say Ghana is bordered by soldiers all around. Now we realize that there are a lot of foreigners in the country, which shouldn't be so. So if we tend to see a lot of foreigners here, what does it mean? It means that the borders are weak. Do you understand? It means that the borders are weak. So if we tend to find high level of protein in the what? In the CSF or in the brain, they realize that there is what? There is a how do you call it? There is a compromise in the what? In the blood-brain barrier, and that's it means that the patient might be suffering from a condition we call what? Meningitis or hemorrhage or multiple sclerosis. So you can read about these ones. That is what it signifies. Then reduced protein value. When there's a reduced protein value, then we say that okay, it means that maybe some of the protein is leaking somewhere. Now we can also use the what? The glucose to check. Please, are you following?
Yes, sir, we are following.
Yes, sir, we are following.
When the glucose
Yes.
level
Hello,
is also what?
Sir.
When the
Hello,
when the
sir.
glu-
This,
pardon me.
sorry.
Is there a question?
Yes, I needed a bit of a clarification. So,
Okay.
please, can I go ahead?
Oh yes, why not?
Okay, so you said if a test is to be done to find out if the person has meningitis, the fluid will be taken from the spinal cord, right?
Yeah, the fluid is not that it can be taken from there. It is taken from there.
So that's the only source.
Yes, that is where you get the cerebrospinal fluid from, because the
Okay.
cerebrospinal fluid shows the central nervous system. The central nervous system is the brain and the spinal cord. You can't go and take it from the brain, so they take it from this. This is where they take it from, and that's what I put on the
Okay.
slide.
Okay,
So
so
we do a
now
number.
my question is, at our level, can we also issue a request for this same test to be done? And if
Yes.
yes, is it sent to an orthopedic doctor, or who exactly does this? Is it
Oh, for
anesthesian,
for lumbar
anesthetic?
puncture. Okay, let me answer. For lumbar
Thank
puncture,
you.
anesthetists do, doctors also do. Doctors also do. How do you call it? These physiotherapists, people, they also do. You understand? The person has to be qualified to do it. So doctors do, anesthetists do, yes, and sometimes house
Okay,
officers,
thank you.
physiotherapists also do. Yeah, but maybe you as a naturopath, your job description doesn't qualify to do a lumbar puncture. So you request it, and some of the diagnosis centers they have people who take the sample. They have visiting doctors and or how do you call it, anesthetists who come to take the sample and do it. Yeah. So that is it. So and also we also talked about what CSF glucose usually reduced when foreign cells such as bacteria or elevation of white cell count. So when there is what, there's also a bacterial infection. Now we have talked about the glucose. We said that we are liking the glucose to what, when the borders are weak and we find foreigners inside. So for instance, when the blood-brain barrier has been compromised and we find protein inside the what, inside the brain, we say there is what, there is a break in what, the blood-brain barrier, and it can be as a result of what, meningitis. Now when you look at the glucose, when you check the glucose levels too and the glucose level are low, it's a sign that there is a meningitis, there is a bacterial infection, possibly meningitis. Why meningitis? Because meningitis is very common in our setting here. It's very common, especially when you go to the north, those highlands. It's very common there. There's the meningitis is for one group of people. I mean, one particular group. You'll be talking about meningitis. Please, when you're talking about meningitis, talk about the signs of meningitis. Don't forget that, the signs of meningitis. This is medicine class, or no, this is not medicine class. Okay, this is biochemistry class. So those of you who are talking about, it's the same class, right? Yeah. So those of you who are talking about meningitis, talk about the signs of meningitis. Very important. Okay, the Brzezinski sign, the Kennan sign, very important. There are two major signs: the Brzezinski sign and the Kennan sign. Very important. Just touch on that one too. So that is it for the, I mean, for the meningitis. The one who has the question? Have you understood?
Yes, sir.
All right. So this is for pleural effusion. So it's just like either there's an exudate or there's a transudate, whether there is a bacterial infection or something, or there is a trauma that is causing the leakage. So you read as such, you understand. So this is how it is done. So pleural effusion, so this is how they do it. You make the patient sit down. We call something the safe triangle. So there's a place we insect. There's a place we insect, depending on where the effusion is. Either it's on the right or on the left. Okay. Yes. So we call something the safe triangle. We call it, we insert it that way so that so that you can dodge the liver, particularly when it's on the right. When it's on the right, you have to be very, very, very careful. Even if you can do it under an ultrasound, is very good so that you don't go and puncture the liver. Yeah, because if it's on the right, the chance of puncturing the liver is very high. But we call something the safe triangle for inserting the chest tube. So this is how we insert the chest tube. This is where they insert the chest tube. Pleural effusion. Let me give you a picture of that. Any question, Mr. Philip?
Yeah, no.
Yeah.
Thank you very much. Thank you. Yes, concerning the CF, the lumbar puncture. In fact, I had an experience with my daughter. When my daughter was 1 year old, she started experiencing seizures.
Okay.
So so he was taken to the hospital and the doctor requested for that. So my question is that they said they did that, taking out the fluid from the spinal cord. But my question is, how can the seizure, how does it relate to that? Like, if they are checking for the seizure and they are taking that cerebral fluid.
I understand you. Don't worry yourself. I understand you. I've understood your question. Okay. I've understood your question. Yeah, you want to know why why would we go and do a lumbar puncture for someone who is having a seizure, right?
Yes.
Yeah, so seizures happen from the brain. The glucose and the liver are just two of the, I'm saying the glucose and the protein are just two of the parameters they check, but there are a whole lot of parameters that they check. Okay, so seizure can be that maybe there can be high potassium levels, high calcium levels, high oxygen levels, high this, high that, and so that is accounting for what? For the seizures. And each of them have their. If I say we are delving into lumbar puncture or the CSF is a whole topic on its own. You understand? So yes, it makes us know because whenever there's a seizure, it makes us know whether there's high level of potassium levels or whether there's high level of chlorine levels or there's low level of this, so that the biochemist will know whether that is so that the how do you call it? The clinician, the one who is requested, will know whether that is what is causing the what? The seizures. Because the brain is such that everything should work in normal. So when there is high level of one, now let's look at which one is high so that we can give medications to combat it, or we can give some how do you call it? We can put out some measures to what? To reduce that level. So let me see. CSF. So with the CSF report, we check out for what? For the pH as well. Check out for the calcium, the potassium levels. Let me give you a picture of it. Copy that. So you see, this is what a normal CSF analysis. So we want to look at this to look out for where the problem is. That is why we do it. So the protein and the glucose are just two of the parameters. But then we need to look out for what? The pH. Is the pH in normal state? If the pH is not in a normal state, it can cause seizures. If the potassium and the what? The chloride or the phosphorus levels are not in normal ranges, they can cause a problem. So you understand? So that is why we do it. And with studies, you get to know, if we delve more, we get to know that when this one is high, when this one is low, it causes a lot of this. Because bear in mind, seizures don't come alone. Seizures come as a result of what? As a result of what? Disturbance or how do you call it? Irregularity at the neuromuscular junction. Okay, at the neuromuscular, at the junction where the brain cells meet the muscles, that is when we have those problems. So when there is what? A chemical problem that is causing either glucose levels to go up, either calcium level to come down, either potassium levels to go up, due to the state of the person, it can cause a seizure. So that is why we normally do a CSF. They take that sample to check for a seizure. Do you understand? Do you understand? Oh, is he not there?
Yeah, we understand.
Yeah. So this is just a picture of how a CSF report. I've just played the picture in your slides so that at least you get to know some of the things that they look out for. But then we are focusing on the what? On the glucose, on the protein, normal chemical examinations. These are at the chemical levels. That's what the commonest one they normally look out for. So that's pleural fluid. That is a safe triangle. That is how we do the tapping. Some other biochemical stuff that can be done about these ones. Now let's look at. Is there any other question? Let's go to kidney function. Okay, so when you look at kidney function, we are saying that what There are about 4 or 5 parameters of the kidney function. We have the sodium, the potassium, the chloride, the creatinine, the blood urea, and nitrogen. Blood urea and nitrogen. So we are saying that blood urea nitrogen BUN is a waste product of protein metabolism, and its secretion falls with kidney disease, raising its level in the blood. It is also sensitive to dehydration. So when there's a problem, ideally blood urea and nitrogen, you say is a what? The BUN is what? A product of what? Protein metabolism. So who is to secrete it out? The kidney is the one to bring it out. Okay. After metabolism after protein metabolism, the kidney has to bring them out. But when there's a kidney disease, they tend to build up and it goes to cause a problem. The next one is creatinine. These are what? These are, how do you call it? These are substances, I'll say components or how do you call it? Molecules that need to come out of the what? Of the body through the what? Through the kidney. Bear in mind, the kidney does what? Excretes, has excretory what? Function. So a waste product of muscle metabolism, which accumulates when the kidney fails to excrete them in kidney disease. So when muscles are also undergo metabolic activity, there is what? A product we call the creatinine. And this creatinine needs to be excreted by the kidneys. They tend to build up when there's a kidney problem. So we normally say BUN to what? To creatinine ratio. When the BUN to creatinine ratio is what? 20:1, it indicates what? Kidney disease or a diseased kidney function. Now we look at calcium levels. Elevation indicates kidney function dysfunction and predicts those at risk of kidney stones. So ideally, the kidney should be able to what? Excrete the leftover calcium that has been used by the body. It has to be excreted. But if they build up, so all these ones are components that need to be excreted by the kidneys, but then because the kidney is at fault, they tend to build up. Sodium, potassium, and chloride, these are electrolytes. And their balance is being maintained by what? Are being maintained by the what? By the kidneys. The kidney has to keep a threshold of it and also excrete some. But with a default kidney, it does not help with it does not control the balance. So it can either be that it will sieve them out or it will keep them all. Do you understand? So we say that what? In situations whereby they are very low too is a problem. And more often they if in kidney disease, more often they tend to what? They tend to be elevated. Because the kidney who has to do the balancing work is at fault. So this is what? This is a classical example of what? Of a kidney function test. Let me show you an example of a kidney function test at my clinic. Come in here. Will I even get someone? Give me 1 second. It's okay. I'll get that and put it in a page for you. Okay. Yeah. So this is how it looks like. Now, there's one thing that we always focused on the major one that we always focus on is the creatinine level, because that is what we use to determine the stages of kidney disease. Now we call something the EGFR. EGFR is the what? The estimated glomerular filtration rate. EGFR. You see, we call something the EGFR calculator. We'll learn this one in medicine, but let me just open your eye on it. Because something the EGFR. The EGFR. So the EGFR makes us know the stages of what? Of kidney disease. So this is the stages of kidney disease. So these ones are what? Are the EGFR calculations. EGFR is what? The estimated glomerular filtration rate. The glomerular is the point where the filtration occurs in the kidney. So the EGFR is giving us an estimate of how the glomerulus is able to do the filtering. And one parameter that is very, very important that the biochemist uses what? Is a creatinine. That's the metabolite that is good, that the end product from what? From muscle metabolism. Now we are saying that with the creatinine, it should be in range 97 to 137 for what? For men, then 88 to 128 for what? For women. Then we have the stages of kidney disease. So we are saying that if you calculate the EGFR, there's a way we calculate it. You use the creatinine, then you use let's say the age, then the race. There's a way when you finish, you can go and search for it. EGFR calculator. Or should I search it for you now? EGFR calculator.
Yes.
Yes.
Because something, so you can have a look at it. EGFR calculator. That is what we normally do. That is what we use to check for. We say someone is stage 1, stage 2, stage 3. How did we know? We use the EGFR calculator. If I'm teaching you for both chemistry, for medicine and this one also. When I get there, I know I've taught you. So EGFR calculator, that is what we use to check whether someone is stage 1. We say someone is stage 1, stage 2. How did we know? We use the what? We use the EGFR calculator. Oh, I'm coming there. EGFR. Okay, so let's see. Oh, Mr. P, I'm suffering. Oh, the way this thing is stressing me. Yeah, I think I'm there. So that is the EGFR calculator. So you just go online, search the EGFR calculator. They normally use what? The gender, the age, and the creatinine level. So it means that your gender, your age, and the creatinine level will determine your what? Are the parameters that determine your what? The kidney function. So let's go into it. So you see the gender. is what? Male or female? Let's say male. Now let's look at the age. Let's say 70 years. 70 years. Now let's say the creatinine level is, let's say, 120. Then normally you have the milligram per deciliter or the micromole per liter. That's what we normally use, the micromole per liter. It is selected already. Then you view results. So a man, a 70-year-old man with a creatinine of what? 120 has this EGFR. So 56, this is the EGFR, 56, okay? So with 56, we can say this man is what? It's stage 3B. Looking at the stages of what? Of kidney disease. You have the slide, eh? I give you the slide. Stage 3, we say stage 3. Stage 3, you understand? So that's how we calculate the EGFR. So you just go online, just search EGFR calculator, then you'll be following like that. Now let's look at this one. Let's do another one. So the gender was male, the age was what, 70, and the creatinine was what? Was 120. What did we get? We got 56, right? Right? Let's do another one. Now let's choose a female, the same age, the same creatinine. Did you see what we got? 64. You see the difference? So the gender, the age, and the creatinine level plays a vital role in what? Are the three parameters we use for checking the EGFR. This person's EGFR is what? It's 64. So if you're a man at age 70 and your wife is at 70, and both of you, your creatinine levels are 70, per your age, your EGFR is better. The woman has a stronger kidney function than that of the man. That one I can't tell for now. I'm sure that question will come, but I can't tell unless we go and do more research on it. You understand? But then that's it. So that is how we calculate the EGFR. And the EGFR, so this is 64. So look at the slide. Do you have the slide? I think I've given you the slide. So 64, if you see 64, so it means that what? It's going to be what? 64. So these are the ranges. So more than 90, 89 to 60. Stage 3 is what? 59 to 30. Or let's pick it this way. 60 to what? 89. 30 to 59. 15 to what? 29. And less than 15. So so you realize that the man will be what? Stage 3, and the woman will be what? Stage 2. But they are all at the same age, same what? Creatinine. Any question, Mr. Nicholas Elijah?
Sir, my questions is about the kidney. As I'm speaking, I'm not in Ghana right now. I'm Togo. I'll be coming back. My questions is, as a naturopath,
Okay.
what are some of the parameters or the equipment we can use to check or to determine if the person has a kidney? Because the reason why I'm asking, most of the time the person will be coming to your facility, will be complaining, she or he has a kidney problem without any hospital checkup and those things. And aside the physical symptoms, some of us will know. What are some of the equipment or the parameter we can use to determine whether it is kidney or not?
But you are answering yourself. Why are you here? There is the equipment you need is what you are learning now. Eh?
Okay.
That is why you have come to school.
Thank you.
Yes, that's why you are in school. So that's why we are now teaching you what to do. You need to request for a kidney function test. And if you are requesting for a kidney function test, what are you looking out for? You are looking out for what? The parameters, the creatinine level. you are looking at to calculate the EGFR. When you calculate the EGFR, it makes you know that this person has what? Has a stage 1, stage 2, stage 3, stage 4, stage 5. And it's making you know that here, we say what? Stage 1 is what? Slight. Stage 2 has a mild what? A mild kidney problem. Stage 3 is moderate. Stage 4 is what? Severe. Stage 5 is what? Approaching failure. So you doing the liver the kidney function test, and you be able to interpret it.
Thank you.
Mr. Nicholas, are you there?
Please, your microphone should be off, please.
Mr. Nicholas, are you there?
Yes, sir. Thank you, sir. I understand.
And you being able to interpret it becomes your tool. Becomes your tool that you need.
Okay.
You don't need any tool. The tool is what I'm showing you now.
Okay, sir. Thank you.
Please, my hand is up.
Don't worry, I'll put it down for you. Don't worry.
Please, my hand is up.
I'm coming. I'll put it down for you. Don't worry. Do you understand?
Yes, sir.
Yeah. So that is it. So, Madam Theresa.
Yeah. About some 40 years ago,
okay,
after I have delivered my first daughter, I was getting sick. And when I got to the hospital, the doctor hit my back very hard, in between the ribs to the lower portion. And when I reacted, then he said, I'm having a kidney problem. How does that one account for? I want to understand why he did that, and he was able to say I had a kidney.
Okay. So what you have will not necessarily be okay, let me show you what he did to you. Okay, I love pictures, so let me show you. Did you get her question?
My photos and picture video.
The microphone has done what?
Those microphones are on. Should kindly turn it off. Go to one.
Put your microphones off. Oh.
I mean, your number. Make sure you do why.
Why not do a number now?
Really, I'm here chill. Who do you never?
Mr. William,
Yes, sir. I'm still waiting for the answer.
Oh, who is talking now? Whose microphone is on like that?
I think it's Mr. Williams. Mr. Williams, please mute your microphone for us, we beg you. I'm not sure he's listening to us. Sir, please, you are the host. So maybe you can help to mute him for us.
I can mute him. Where is he? Who is that? Mr. Williams?
Yes.
How do I even mute him? I'll remove him.
So you click on his name and then it will pop up. Don't watch me, and then you just click on me.
What I have here is remove from the call.
No.
And I have don't watch.
They're supposed to be me. This is the host.
Maybe you should go and come back. Maybe you should go and come back. Since he's not hearing from us.
Oh,
you just remove him. Then you join us again.
I think he has been removed.
So he was the one,
Yes.
Okay, he's not in class. He has put the phone somewhere. He's making noise. He's not in class.
So please, now I'm watching to get my answer.
Don't worry, I'll give you your answer. Your answer is right in your hand. Okay. Your answer is right in your hand. I love pictures, so let me show you so that you appreciate it. Okay, so you could see that look at this one. You see where the kidneys are?
Yes, sir.
This is the person's back. You see where the kidneys are? Is that where the doctor hit?
Yes.
Yeah. So we call this one the renal angle. We call them the renal angle. So normally we do renal angle. We check for renal angle tenderness. He was checking for renal angle. So we call them where the doctor hit. At the back, in between your ribs, we call that place the renal angle. So normally we do a blow over there. Not a strong blow to hurt you, but something light. But if there is pain, if there is an infection, you are going to feel the pain. So what happens is that one is used to check for a condition we call pyelonephritis. There's a condition we call pyelonephritis. And mostly it's an infection around the what? The borders of the kidney. It doesn't mean that there's a kidney function, there's a chronic kidney disease or something like that. Those ones normally they are acute and they are normally treated by what? By antibiotics.
Okay.
So you realize that when he did that, didn't he give you antibiotics?
Yes, he treated me and I've never had any kidney problem again.
Exactly. So you didn't have a kidney, you weren't having a chronic kidney disease, it was an acute one. It was mostly as a result of an infection. So there's a condition we call who has heard of that before? Pyelonephritis.
How can you spell that for us, please?
Yeah, it's on the slide. It's on the slide. You can look at it.
Okay.
So normally it starts from a urinary tract infection, and normally takes an ascending infection. Normally a urinary tract, you get a urinary tract infection that is not well treated, and you realize that it travels up. So if you can remember that you were having a urinary tract infection some way, or you were having some lower abdominal pain, was there any like that?
In fact, it's been over 39, 40 years now, so I can't remember all that detail, but I just knew he hit my back and I reacted, and he mentioned that.
Okay, that's
yes.
true. So normally it starts from what? Normally it's from an infection. It has an infection origin. Normally from a urinary tract infection. So this one says something.
Okay. Thank you, sir.
Urinary tract infection that is causing that. So you see, this is a normal what? This is a normal kidney, and this is a pyelonephritis.
Okay.
Do you see the difference? You see that
white portion.
You can see that some fluid is covering the what? Some fluids are covering the what? The compartments of the what? Of the kidney. That's the pyramid.
That white lining.
Yes, and also look at the contour. Look at the contour of the kidney. Look at the contour. The costophrenic angle. I say the costomedular differentiation. Realize that here is fine, here it is not fine.
Okay.
So what it did, so that condition is called pyelonephritis. And it's normally that one is not a chronic kidney disease. Someone can have pyelonephritis, but his kidneys are very fine. Their function is very fine.
Okay.
So it only affects the structure. And normally, because it's an infection, when you hit there, it causes an inflammation. You understand? So it's just like, bear in mind the organs in the body are just like the organs that you see, that you can see. Those you don't see are just like those you can see. So anything that can happen to those you can see, the same thing can happen to those you can't see.
Okay.
Do you understand? Anything that can happen to the external organs, Same can happen to the internal organs. You can fall down and get, how do you call it, a bruises or a contusion around your arm. The same way, you can fall down or you can get an accident and you will have what? A trauma to your kidney. And it can
Okay.
cause inflammation of the kidneys. You
Okay.
understand? So pyelonephritis can be an infection, can cause that, a trauma can cause that. You understand? It can cause an inflammation. So any inflammation, so the pain that you felt was because of what? Of the inflammation that was
Okay.
occurring around the what? Around the kidney. But then when it comes to the function, it's the kidneys function. In the long term, we will not say no. Maybe within that period, there can be a slight changes in the kidney function. But after that pyelonephritis is treated, your kidney goes back to normal, and you can attest to the fact that up to now your kidneys are fine, right?
Yes, sir.
So
In fact, it
that's
was immediately after delivery.
okay.
And since then, I have never experienced anything like that. But
So it was
because we
an
are
infection.
learning this, I wanted to ask.
Yeah, so that was a good one. At least you have opened our eyes to certain things. We are all learning.
Thank you very much, sir.
You're welcome, Mr. Amevoji Kingsley.
Thank you, sir. Mine have to do with the buildup of uric acid in the kidney and also lipoprotein in the kidney when the kidney is not able to do away with it. And also the relationship between the kidney and edema. I want to know what health conditions may be prevailing when these things pop up. Thank you.
Okay, your questions can be answered, but it would demand that I explain a lot. Kidney and okay, let me start from the down. Kidney and edema, it stems from the fact that the kidney helps in blood pressure regulation. There's a part of the kidney, what we call the kidney produces a hormone we call the renin. We will learn about the renin-angiotensin mechanism in hypertension. So the kidney is the one that is producing that. Do you know that the kidney helps in regulating your BP? Yes. So you realize that anybody who has a kidney problem will have a what? Before the person will start getting the edema, the person will have what? Hypertension. Why? Because the kidney produces a hormone called the renin. The renin binds with angiotensin 1 to prevent conversion of angiotensin 1 to angiotensin 2 by the enzyme angiotensinogen. So if this one is, if the kidney is at fault, it means that the kidney will not stimulate the production of what? Of renin. Now this renin helps to prevent how do you call it? High blood pressure. Now, when there is no high blood pressure, the instances of edema is reduced. That is one. Then the fact that your kidney is also not being able to do what? Perform its function of what? Of excretion. Excretion. What does the kidney do? It removes excess water from the body, right? Now the kidney has a problem. So what will happen? It means that all the fluid that has to come out, you have to urinate to come out, is not coming out. There's a buildup of fluids in the blood vessels. So what will happen? Some will have to seep into what? Into the what? Extracellular spaces. When it happens that way, what will happen? You become bloated up. That is what causes the edema in what? In kidney function. So there are multiple causes. Do you get it?
Yes, please.
Yeah. You guys you are draining water out of me. Oh, hey, you're making me explain plenty. It's not easy. Oh. All right, let's continue. Do you get it? I mean, at least you have gotten it. So do you get it now?
Yes, I've gotten it, sir.
I'm sure your colleagues have also gotten it.
Please, I have a question.
Yeah, you will. But let me take some water break. Write your questions down. Let me take some water break and come.
Okay.
Let me get some water too. clear my throat and come. Keep your question. I'm coming in. Oh, my machine is running down. Give me some 5 minutes. Let me 5 guys to maybe some 3 minutes. Let me connect my machine.
This is a wonderful class, isn't it?
Yes,
Really, we enjoyed it.
Well done. That's good. It's because we are practitioners. That's why.
Are we back from water break?
Not really.
Water break and bathroom break for us.
Okay, so thank you. So I want to ask the difference between this pyelonephritis and renal cyst.
So, but that's different. So, renal cyst is when there's a cyst in any of the what? A cyst is just an accumulation of fluid. You understand? Either in the cortex or in the medulla of the what? Of the kidney. So let me just show you one. So the cyst, yeah, those ones, some of them they are self-limiting, and it goes on their own. You understand? But the pyelonephritis is what? It's an inflammation. So you see, these ones are what? These are cysts. Some of them they are self-limiting.
So how come a patient was having this renal cyst, the doctor have transferred him to Kolebu for surgery or kidney transplant?
Oh yeah, it depends on how it is, because sometimes some of them too, how the cysts come about, some of them they tend to become malignant at the end. But I'm just making you know the difference that the pyelonephritis is different. A cyst is a cyst. I mean, accumulation of how it came about, either from a malignancy, either from maybe some medications, maybe for some autoimmune conditions. That is it. You understand? So look at this one. Look at something like this. If it takes for a very long time and they realize that it is not, it's not rupturing on its own and it's getting bigger, and it means that it's going to affect the function of the kidney at that particular level, it means that yes, they will have to go in and do a surgery for it. You know, like, and some, as I said, some can be malignant, some can be bad. Look at this one. Look at this one. Some can be bad. And so some of these things, they don't rupture. And the small ones are those that do rupture on their own. But then something like this, something big one like this, you obviously they have to go and excise it. Let me show you. So I think there's even a classification there's even a way they classify some of them, wherever depending on the size and the location. Because you see this one is what no septa, Bosniak 1, Bosniak 2, when there's what 1 to 3 septa, when there's more than 4, when there's what 1 thick membrane, when there's what 1 more input. So the cysts, some may resolve, but if it doesn't resolve and it's getting bigger, then it means that it's going to affect the kidney functioning. And you have to be referred for. Look at this one. Polycystic kidney disease. Have you seen this?
Yes.
Yeah, so there's something like this. No, it's not inflammation. Oh. It's not pyelonephritis. Oh. Yeah.
You
What are the questions?
prayer, like early morning, how you started early morning. That one there if you prayer because you think normal,
Is that what the
Pentecostal song.
questions?
Come the letter pass it, then go sing the
Mr. Menu
song.
Charles, you have a question?
Alpha and Omega, please mute your mic.
I'll take him off right now.
The way the song being here, yeah, because the song will be
Alpha and Omega.
minor.
He's not here. He's not here. Mr.
I'm
Menu
here.
Alpha and Omega.
I'm here.
Menu Charles, are you here?
Yes, sir. I'm here.
You have a
My
question?
my question has to do with hydronephrosis. Hydronephrosis. So how is that one to do? I mean,
Hydro what?
Hydronephrosis.
It comes from the name. Fluid accumulation in the. That one is not inflammation.
Oh, okay. All right. Thank you.
Fluid, hydro, fluid. And mostly, as a result, it normally occurs in how do you call it, dysfunctioning kidneys. So you realize that the fluid accumulates and makes the kidneys tend to become bigger because of the fluid accumulation. And what normally happens is how does the hydronephrosis occur? You see, it happens in some conditions. Okay, it can be that one, like you were saying, the edema formation. So you realize that the kidneys have produced the urine into the bladder, but then there's a problem of the urine coming out. There can be a reversal of the fluid back into the kidneys and can cause the fluid accumulation. For instance, okay, let's see this one. So look at this. This is a healthy kidney, a hydronephrosis, you see. So the bladder is unable to empty. For which reason the bladder is unable to empty? There can be multiple causes. There can be a prostate condition. There can be a bladder injury. There can be a urethral calculi. When there are stones in the urethra. So the pressure is transmitted to the kidneys back. There is fluid in the kidneys. And that one can result in fluid accumulation in the kidneys. This fluid is what? Is the clear fluid that was produced from here back to here now. It's going back. Then we have so this hydronephrosis will make one of the kidneys gets ballooned or swollen up. You understand? Look at this one. You see that? Yeah. Is that all? Right, let's continue. So that is the way we can get to know how the kidneys are functioning. So now, you as a naturopathist, now you're not going to be seeing kidney patients and look at them raw like that and give them any medicine to go and take without requesting for a kidney function test. Do you understand? You will request for a kidney function test, at least know the creatinine level. They will come with their
Yes, please.
They normally come with their what? Their ranges. So you get to know that they are up. Then you use the creatinine to calculate the what? The EGFR. Then you get to know that, oh, this patient is what? Stage 1, stage 2, stage 3. Then you can just read online. What are some of the foods that stage 3 should eat? What are the food that they should avoid? That is how you're going to advise your patient to. Then you come with your naturopathic, as a naturopathist, yours is more of prevention. So you come in with what? With your education. Because you know that this person is what? Is stage 2, stage 3. You know what might happen if the person doesn't stop what he's doing. If it's alcohol, if it's excessive toxic herbal medication that the person is using, if it is smoking, if it is, eating of too much junk foods and oily foods thereabouts, that is causing a problem, putting stress on the kidney, you know how to advise the patient. Do you understand? Yeah. Now we go to the liver function test. So as a naturopathist, you also request for what? For the kidney and the liver, very important. They are the common ones you are going to see. The pleural fluid, maybe once a while, pleural effusion, once a while you might see. The synovial fluid, once a while you might want to do them. The CSF, once a while you get a case like that, you might want to request, you might want to check those things. Even with you, most of them, you will have referred them. But then you need to know. But for the liver function test and the kidney function test, very important. You would have to request for them. So the liver function test, we are looking out for what? The albumin, the total albumin, the conjugate bilirubin, then the what? Then you look out for what? The liver enzymes, the what? The AST, ALT, GGT, alanine transaminase, aminotransferase, aspartate aminotransferase, gamma glutamyl transferase, alkaline phosphatase, ALP, AST. They are what? They are just the what? The liver enzymes. They are high parameters, shows that what? There's a problem with the liver. Why? Means that when there's a problem with the liver, they tend to be released the more so that they can what? Combat the problem. So the reason how we can only know there's a problem is when their values are what? Are high. Do you understand? These are parameters that you will not see. Albumin, total albumin, conjugate bilirubin, and those ones you will not see. You wouldn't see them. They are not like their hand, or they are biochemical. They are biochemical, so they are seen at the what? At the biomolecular level. So you will not see unless you what? You combine two reagents and what? Do the what? The biochemistry analysis, so that and that is when you see them. So it's only the biochemists who will see them. Do you understand? So when their values are high, we say there's what? A liver problem. And I've put another slide by the side that is showing. Let me put this on it like this. Let me cover this one small. Yes. So do you see it now? We have the what? The alanine transaminase, ALT, normal values 7 to 56. So indicates liver damage. So anything above, anything when it goes above suggests there's a liver damage or there's a damage to the liver. Just like all the liver enzymes, that's how it happens. Now we come to, that's the ALT, the AST, the ALP. Then we come to the the total bilirubin, the total bilirubin. Now you're saying that when it's high, it indicates what? Join this, join this, join this. The yellowy discoloration of the sclera of the eye. Now we talk about direct bilirubin. You are going to see all these parameters on the kidney, on the liver function test too. Direct bilirubin indicates what? When it's high. The parameters are 0.2 to 0.8. So if you get an indirect bilirubin of, let's say, 20, it's high. It indicates what? Jaundice due to what? Hemolysis. Now we're talking about direct bilirubin. Indicate jaundice due to liver disease, bile duct obstruction, or other conditions affecting the bile duct. Now we talk about albumin. The albumin are being produced by what? By the liver. So with this one, we're saying that low levels suggest liver damage, kidney disease, malnutrition, or inflammation. So the food we eat provides some, and the liver also produces some. So when there is a reduction in that, we say that what the liver is what is sick. So that is why it's not able to give us the normal or the required albumin that we need. Total protein. Low levels can associated with what? Liver and kidney disease. Gamma glutamyl transferase is also an enzyme, liver enzymes. So between 6 to 61, that is the normal range. Anything above that, we say that what? There is often indicates liver or bile duct damage. You see, the liver and the gallbladder are more like they are connected together, the bile duct. You realize that most is a hand up, Mr. Menu Charles, is your hand up?
Yes, sir. Yes, sir. My hand. So,
Okay, let me hear you.
okay. I understand the total bilirubin, but talking of direct
I
and
can't hear
indirect,
you.
so what? I said, hello.
Yeah.
I said, I understand the total bilirubin, but the indirect and the direct bilirubin, so what are the difference?
Okay.
Thank you.
Okay. So when we talk about the direct bilirubin, now we are saying that what happened is that we are saying that one indicates suggestive of what? Liver disease, a bile duct obstruction, or other how do you call it? Conditions affecting the bile flow. Now, when there is a condition we call cholecystitis, cholelithiasis. There's a condition we call cholelithiasis there are stones in the what? In the bile duct, causing an obstruction in the bile duct. What happened is that this how do you call it? Bilirubin. The bilirubin, what are the bilirubin? The bilirubin are metabolized from what? From red blood cell, how do you call it? Breakdown. Okay. So what happens is that if there are obstructions in the breakdown, it means the bile will have to pass through the what? Will have to pass through this what? Bile duct. The bilirubin, that's the bile. Will have to pass through the what? The bile duct. But then in situations whereby there is a blockage, it means that and what happens in the bile duct? The bile duct what helps in what? Emulsification, helps in breaking down mostly fats and other components like the bilirubin that passes there. So you realize that in conditions like that, if they are not being broken down, when they are broken down, that is when we see them in our stools and in the urine too, and it comes out. The reason why your stool comes out as yellow and your urine sometimes come out yellow is what? Is the discharge of some of these bile for them to what? To be taken away out of the body. But then in a situation whereby there is a blockage, we say there is what? It's due to what? How do you call it? In a situation whereby there's a problem with its breakdown, it tends to find itself, locates itself in areas like what? Like the palm, the sclera, the sole of the feet, sometimes even in children, the chest area and at the back. They tend to deposit over there. Okay. Now we say that when it happens that way, we say there is what? It is indirect bilirubin because it is not going through the right channel. It has not been emulsified. It has not been broken down. Okay, it has not been broken down into smaller fragments to come out. Now, when it comes to the direct bilirubin, those ones goes to what? Goes to pass through the what? How do you call it? The gallbladder, but then because of what? Because of the blockage. I don't know if you understand. Should I use pictures to explain to you? Let me use pictures. Do you get what I'm explaining? Hello?
Yeah, we are getting.
No, if you're not getting it, let me explain to you, because if you are getting it.
Please, can you also use the picture?
Yeah, we are getting it.
Okay. So the reason why one is because of the fact that it's not even how do you call it, well broken down or well how do you call it, metabolized, and so you tend to find them in what, in the sclera, at the beneath the eye, I mean at the white part of the eye, at the fingertips, at the sole of the feet, and you realize that it's very common in kidney, in liver problems. It's telling you that what, the liver has a problem. Those ones are telling you that the liver has a problem. Do you understand? But then ideally,
Yes,
if it doesn't have a problem, it has to come out through your what? Through your stool, through your urine. So that is what brings the discoloration of our stools. You understand? Maybe I'll read more. I'll get more pictures and more elaborative slide for you to understand that one. So let's continue. I think we have spent too much time on this slide. Then we look at the pancreas. The pancreas. So we're saying that the pancreas also, that one focuses on what? Rises when insulin falls. Glucose rise when insulin falls, as it does absolutely in type 1 diabetes, relative type 2 diabetes. Also measures how effectively the kidneys excrete excess glucose in the blood. It is also a measure of how effectively the kidney excretes excess glucose in the blood. So the kidneys function in a way, I mean, affects the pancreas as well. If the kidney is at fault, it has a way of affecting the pancreas. Because if there are excess glucose and the kidney cannot sieve them out, they are found in the urine. If you go and urinate, they are there. If you take your blood glucose, they are plenty. The sugar is there plenty. It also affects the pancreas. Yeah. So I think we'll end this slide here. Then we continue with one other slide for today. We are looking at lipids today. I said I was going to teach you a full blood count, right? Did I say something?
Yes, sir.
Full blood count. So Some of the major labs that you are going to do are the liver function test, the kidney function test. Very important. You're going to be using them very well. Then the last one is the what? Is the full count, the full blood count. In other words, they will say complete blood count. What are the parameters of the full blood count? What do we see on the full blood count? So let me show you a picture of a full blood count. Who this one is that?
Brother William.
Who is the one? Who is that?
Say, Mr. William.
Please alert him. Alert him. Someone should call him that he's distracting our class. If he doesn't want to come to class, he shouldn't put the phone on. On the call and be making noise. We are learning, though. Or are we not learning? We are learning a lot. Because of listening. The reason why when you ask a question I want to answer is that it gives you an exposure for you to understand something. Because you people, you already know the system already, just that there are certain things that you want to clarify. That is why I give chance for you to ask your questions. Now we have learned numerous things that are not even in the topic, but we are learning and you are picking it. I'm not sure it's going in vain. You are learning. So this is a classical example of what? Of a full blood count. Oh, I've not shared the slide. Look at what I'm saying. Let me share your slide. So you see, this is a classical example of what? Of a full blood count. So in a full blood count, you are going to get the what? These various parameters. You are going to get the what? The hemoglobin level. That is the HB. The one they say the HB, the HB. You are going to get the WBC. That is the white blood cells. And we'll learn what they mean. Okay. Why? Then we'll check the what? The platelets count. Very important. You need to know the platelets of someone, of your clients. You need to know when platelets are low, what does it mean? When we say someone platelet is low, what does it mean? You as a naturopath, you should be able to at least have a look at a full blood count. And you should be able to understand a full blood count. You understand? It should be something that you should be able to do as a naturopath because it is something that you request. From now, if you are requesting for someone's liver function test, at least you add a full blood count to see how the person's HB is, whether there's any infection, whether the platelets are fine, whether the HB is fine, whether the infection markers, the white cell counts, the neutrophils, the basophils, then the eosinophils, whether they are all fine. You understand? And they are all telling you something. So let's continue. You need to know the RBC, the red blood cells, then the MCH, the mean corpuscular hemoglobin. the average hemoglobin that is being picked by the average hemoglobin of the red blood cells. Then we also have the MCHC, the mean corpuscular hemoglobin count. Then the MCV, the mean corpuscular volume. Then we also have the neutrophils. We have the lymphocytes. When the neutrophils are high, what does it mean? When neutrophils are high, it means there's a bacterial infection. So when you have white cell counts high and you have neutrophils high, it tells you that there's a particular bacterial infection that is going on. Now listen here. When we say white cells are high, the white cells are the what? Are the infection markers. Now when we say neutrophils, the neutrophils are what? Are immature. The lymphocytes, the neutrophils and the what? And the monocytes, they are immature white cells. Okay, they are immature white cells. They are, let's say if the white blood cells are soldiers, these ones are what? Are recruits. Or if these ones are police, because they are the fighting mechanism of the what? Of the body. The white cells are the fighting mechanism. The neutrophils, the monocytes, the small ones, the basophils, they are what? They are what? They are what? The recruits. Right? Do you know recruits? Those who are going for training. So let me ask you, at what point in time will we find recruits in Ghana? Recruits. At what point in time will we find them in the public space fighting? What will happen for we to find recruits fighting? Who can answer this question? I don't know if you understand my question.
When there's going to be a war, or expected war.
When is what?
When you're expecting war.
Exactly. Let's give it up for her. When there is a war, what happens? The soldiers will fight, they will be worn out. Now they will have to call in what? They will have to call in what? Immature soldiers to come and also fight. So when you see high level of neutrophils, high level of monocytes and basophils or granulocytes, coupled with high WBC, it tells you that what? There is a strong infection in the body for which even the immatured white body cells are what? Have been called to come and fight. Do you understand? I'm explaining full black count to you for you to understand. Do you understand? So when you see a white cell count, just liken it to the what? The white cells are the soldiers. When the soldiers are high and the small soldiers are also present, it should tell you that what? There is what? A high level of infection. When the soldiers are high and the small soldiers are minimal, are not so many, it tells you that it is something that the soldiers can conquer. When the soldiers are high a little bit, the small soldiers are a little bit. So, and also, whenever the soldiers are high, when the WBCs are high, the eosinophils or the neutrophils are also high. Because why? They are also on the guard. Do you understand? They are also on the guard. So sometimes you can see that their values are not so high apart. They are all a little bit high, because they are all what? They are all gunned up. They are ready to fight. So they will all be high. Do you understand? Now, when we look at lymphocytes mostly talks about viral infection. The ones like the WBCs and the monocytes are talking about bacterial infections. Bacteria. That is more often in those ones you need what? You need to give what? An antibiotic to combat them. Then we talk about the lymphocytes too. Mostly when there is what? A viral infection. When there is like a viral cough in children, rhinorrhea, this influenza and all those ones, it tends to make lymphocytes go up. There's going to be lymphocytosis, lymphocytes go up. Now we come to the MCV, the MCA, the MCHC. They are all and the RBS. They are all parameters that fall under the hemoglobin. So the WBC, when we pick the WBC, the neutrophils, the monocytes, then the basophils fall under the WBC, that's the white blood count. Now, when we pick the platelets, the RDW also falls under it. There's another parameter, and then I think the PCV or so. Then when we pick then the eosinophils, when eosinophils are also high, it's also suggestive of an allergy. When there's an antecedent allergic reaction that is going on, we check for the eosinophils. So, for instance, someone who has asthma, we want to check for the full blood count. We are looking at the eosinophils level to know whether the person has come in contact with any allergic reaction. I'm explaining full blood count to you proper. So follow up. So that is it. I mean, I've just said it in word, but I'll give you a note on that. It wouldn't be just like this. Else, you told me that you didn't. Someone told me he wasn't in class. Yeah. So end this slide here. Then I'll give you the. If there's any question, you can ask while I put in the next slide.
Yes, sir.
Is there any question?
Hello, sir. Hello, sir.
Let me see your hand before you talk. If you want to talk, you just raise your hand, okay? Zara 2. Mr. David, you wanted to talk, eh?
Yes, please. I want to know how would you know about this full blood count, or you request for? You give a request and they'll go and do the test or what?
Yes, this is a hematology test. So you request for it. How do you know your patient's HB at your facility? Do you have a facility yourself?
Yes, please.
How do you know their blood level?
I don't do this, please.
No, how do you check so when they come, don't you check their blood level? Don't you, when you give them medicine, don't you want to know their blood level?
You know, ours is like locally how do you call it? Herbal training. I don't have this naturopath knowledge, but we do use this what do you call it? BP machine to check the BP.
BP machine is for BP. BP machine is checking for BP. So
but
now,
we don't. I never did. Who is laughing? I never did this type of full blood count test.
I get you. That is why you are learning this course. So henceforth, you would want to request for a full blood count test. There are labs around. You would want to request for it. Okay. So you just write on your. You have to get a request form. Now you have to be getting your request form at your facility. If you want
Okay,
somebody
sir.
to help you design one, you can contact me after
Yes,
the
sir.
class. Then I'll
Yes,
show
sir.
you how to design a request form.
Yes, sir.
Then you can request for your patient to go and do a full blood count. What are you looking out for? You want to see the person's blood level, so that if you are giving any drug for blood, if the person comes with anemia and you want to give any naturopathic drug to help with boosting of the blood, you will know the HB. Then you
Okay.
know the result. You know you can compare before and after. Mr. Pierre, are you with me?
Yes, please, we are.
Madam Zaratu, are you here?
Yes, please, sir.
Someone's this one is making noise. Brother David. David Deku.
Hello, sir.
Yeah.
Yeah, hello, sir. Sir, I want to ask this. The way you've explained the WBC, the white blood cells, I want you to look at the red blood cells to the MBC and the others. Can you explain this to
Yeah,
me?
I will do that. I will do
Explain
that.
those ones a bit. Yes.
Hello.
Hello, sir.
I have a note for that on that for you. Don't worry.
All right. Okay.
Yeah, I was explain that. I was just giving you this one.
Okay. Thank you, sir.
You're
I
welcome.
appreciate it. God bless you.
Amen. Is there a hand up, Madam Mr. Amevoji Kingsley?
Thank you very much for the opportunity. I would like to encourage my colleagues to go in for the collaboration that is needed, because if you get in touch with these laboratories, more especially the private ones, they can also help you, because if you send the request and the results are in, even if you are in good collaboration with them, if you don't understand some of these readings, they can also help you, because some of them are trained lab technicians. So it is very important that we collaborate. Thank you.
It's a very
Oh,
nice idea.
we
It's a very
appreciate
nice.
you, sir.
It's a very nice idea also. But then if you continue, I mean, collaborating with them, sometimes they would discuss your issue. I mean, they will discuss with the patient, and there will not be the need for the patient to come back to you again. So this is what I would
Yes.
advise. You have a page. So maybe if you request for a full blood count or request for some lab you don't understand, put it on your page. Maybe if some of us are on the page, we can help out. You understand? And even
Yeah.
and even now,
Yeah. Mhm.
and even now, uh, anything that you want to learn, you can learn it online. So let's say, for instance, you have a high WBC count, high neutrophil level. What does it indicate? When you just type this one into ChatGPT, it will give you what you read a lot about it. Okay. So you should know why you are requesting it. Because if you send a request to a lab technician and you now tell the lab technician, what does this one mean? Sometimes they tend to lose value, they tend to lose trust in you. You understand? So it will rather be best if you communicate with your co-naturopathist, or myself, I'm there, or any of your lecturers are there. If you start working now, we are working as health workers. We are working among ourselves. It is not wrong asking the lab technician, but if it becomes that all your labs you are asking them, that one to it reduces your level of trust. And I mean, I don't know if you understand what I'm saying.
Thank you very much. Personally, what I do is I research about it before I even make the request. That is having checked the person's BMI and other vitals, and then knowing the disease prevailing. Before I make the request, I research to find out what type of request I have to make.
That is
And
excellent.
just as you said, it is the AI that is aiding. And when the results comes with the AI, you can also understand the interpretation. I
Exactly.
said that regarding those people who may not have the flair regarding the use of the AI. Thank you very much.
That's fine. That's fine. So it's good. You can anything that you want to say, you can search online. If you don't understand, you can put it on your page. There will be someone who has knowledge about it. Okay. Uh-huh. Uh, so I mean, you are learning this course for a reason, oh. Now, after this course, you shouldn't be going to do the local one, treating blindly again. Do you
This
understand?
might have
Now we are talking about what? Investigations. We are talking about how do you call it?
Doc, my hand is up.
Researching.
Hello,
I said
hello,
my
are you
hand
there?
is up.
Yeah, I'll call you. I'll call you. I want to talk about something. Now we are talking about investigative what treatment. You understand? Whatever that you are doing, there should be what something backing it. Okay, and that will make you a good naturopathist. You understand? It will make you a good naturopathic doctor. So that if you are a naturopathic doctor, you are treating somebody for kidney disease. You know the kidney function. You know that this person is stage 2. You know that this person is stage 3. You even know that this person is stage 5. And so stage 5, your medications are not going to do anything to the patient. The patient needs dialysis. You not keep this patient at your place. If you have this at your fingertips, it will help you. It will not make you treat blindly again. You will not do the local things like that again. Now you'll be requesting for labs because the only thing that you are biochemistry. One thing that you also pick from here is what your ability to add investigations to your to your treatment. You request for lab. You request for scans. You request for what for X-rays because now you are learning it. For instance, somebody comes with a chest, tells you that he had an accident. He had an accident and I mean had a trauma of the chest, has had a trauma in the chest. This person comes to you with what? With difficulty breathing. What are you thinking? Yes, what are you thinking about? Comes to you with a trauma in the chest with difficulty breathing. What are you thinking about, Mr. Samuel? Oh, I'm asking a question. Oh. I've given you a case scenario and I want an answer. Hello, are you there?
Sir, yes, please, sir. You
It's not
said
the question is not to you alone. No. I'm asking a general question.
You
I'm
have to
saying
start investigating. You have to start
no
asking
before you,
for
no before you talk,
X-ray.
you have to raise your hand. Though I don't want talking here and there. Before you talk, you raise your hand. Mr. Samuel, is your hand up? Mr. Samuel, is your hand up? Oh, what is all this? Kumsin Daniel, Mr. Kumsin Daniel, is your hand up? Hey, you can't hear me.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
We can hear you.
Sorry.
Is your hand? Do you want to answer the question
Okay.
or you are asking the question?
Yeah. I want to try. Do I hear you?
Okay.
Okay. So, so maybe the person is suffering from heart attack. I don't know whether my network is clear.
I can hear you. I can hear you.
I'm not hearing you.
Someone had a, okay, that's one. Any other? Mr. Samuel, Mr.
Please, the question is not clear to me. I
I'm
didn't get
saying,
the question, please.
I'm saying that someone presents to your facility had an accident, had a trauma to the chest. I mean, had a trauma to the chest, and now presents with cough and let's say difficulty breathing, what are the things that comes into your mind? What are the likely things that comes into your mind? Cough, difficulty breathing, trauma to the chest. Yes.
Doc. Hello.
Wait, I'll call you.
Okay.
Mr. Okay, Blessing. Blessing, let's hear you.
Yeah, there will be a possible accumulating of pleural fluid at the lungs.
Okay. Yes. Any other? Any other, Madam?
The lungs are blocked with blood. There be a clot in the lungs that made him not to breathe very well.
Okay. Any other, Mr. David? Rutherford.
Okay, sir. So with this case, you need to investigate the person carefully. For any trauma or accident, you need to do LFT, liver function testing, see if there's any internal bleeding. Also, do an X-ray and see whether there's any breakages or anything affecting the ribs of the person. And finally, see whether if there's any fluid there, so that we can know what to do for that person. Thank you.
All right. Any other, Mr. Amevoji?
I also think that the immediate thing to do is to give the person the first aid. That is to enable him breathe well as you continue with the necessary investigations.
So what do you do?
Thank you.
What will you do to enable the person breathe well?
You do the artificial. Okay, you briefly you make the person lie down flat, and you begin to press the chest in order to help him have the airways cleared for the breathing to be improved a little.
By the time you finish, your patient will be dead.
Pardon?
By the time you finish, your patient will be dead. If you put the patient down, you press the airway, the patient will be dead. Okay, so you don't do it that way. I'll explain to you. Yeah. Okay. So, Madam Christiana. Christiana.
Yes. So I would first of all, yes. So this is Christiana. So I would first of all issue a request out, and one of the requests would be a full blood count to find out if there's an infection, and if it is, and then there's a need for follow-up test. Then I'll proceed into that. But then with the full blood count, if there's an infection in there, maybe as a result of the accident, then quickly medications will be given. If we have maybe antibiotics, the natural ones, to help in the breathing, and then subsequent tests will be done if there's a need for. Thank you.
Okay, any other? Mr. Samuel.
Morning. Okay, thank you, sir. So
This is Eunice from Jamaica.
Samuel Ata Konedu.
Yes, sir. So you made mention of trauma. So because of the trauma, the person needs to undergo a scan to determine what the actual issue is. Thank you.
Okay, so what scan are you going to do? What scan are you going to do? Okay, Madam Eunice, let's hear you.
This is Eunice from Jamaica.
Right.
First, you can do a chest X-ray, or you can do an MRI. Say you're doing MRI for the mammogram for see if it's cancer of the breast, or it could also causes from trauma or inflammation in the bone, a cause from dental clots. That could also happen too.
All right, that's fine. Yes, any other? Okay, the last one, Mr. Samuel Keafachal.
Okay, thank you. Initially, I was coming to ask a question that you brought this question. So, for me, I will ask or maybe the person will be having asthma. That's first, or maybe heart attack. That's the second. Or I'll ask for COPD. I think chronic obstructive pulmonary disease, which is the X-ray to show if he or she is having a chronic inflammatory in their lungs. Thank you.
Okay, so that's fine. You all have your points. I mean, well said. But then it's simple. I've discussed this one right now. I just discussed this one right now, and I gave you a situation. I give you a scenario. The scenario is someone comes to your facility with a history of trauma to the chest, with cough and difficulty breathing. Trauma. It can be that he has been pierced. It can be that it's a stabbing. It can be that there's an accident. So over here, one, full blood count is not the first thing you have to do. Please clear that for your mind. The next thing is that it's not really about the heart or something like that. You understand? Yes, the heart can be there. You understand? But then the presenting complaints, the first thing that you have to do is to take a chest X-ray. What do you have in mind? You are having a pleural effusion in mind. The difficulty breathing in pleural effusion, it will cause difficulty breathing. Look at this. Look at this. Look at how the person is sitting down. Look at this. Look at this point. Meaning that over here, can you breathe underwater? Can you breathe underwater? When you are in water, how do people get drowned? Because underwater there is what? There is low oxygen. Do you understand?
Yes, sir.
So at this point here, there is low gaseous exchange occurring here. So the person is what? Is in difficulty, is in distress. It is just like the person is underwater. It's like the person has been drowned. The person is drowning. So he's gasping for air. He's fighting for air. And there's a trauma. So the trauma resulted to what? To the transformation or to the transudate formation. So it's not an exudate formation because it is not like the person is having a long cough for maybe 5 years. I didn't talk about fever. I didn't talk about infection, anything. So the full blood count is not the first thing that you have to do. You will do full blood count, fine, to know whether the HB is low. Maybe the exudate is what? Is bleeding. So you do a full blood count. But how will you do a full blood count? You need to look at the chest so that you are looking out for this. Whether there is what? Whether there is what? There's a pleural effusion. That's what you are looking out for. So that is why you need a what? You need an X-ray. So if you have never requested an X-ray as a naturopath, henceforth, request for an X-ray. In cases of chest trauma, anything about a chest, cough, and all those things, request for an X-ray. Because this person is, look at it too, he said trauma. Trauma is one, cough, difficulty breathing. And as I said, look at this, if here is all fluid, can gaseous exchange occur here? Can there be gaseous exchange occurring over here? Hello?
No.
Can we have gaseous exchange occurring here? No.
No, please.
Blood vessels
They're
are
here.
what? There is edema at the area. There is fluid accumulated at the area. So if there's fluid there, it's like the person has been placed underwater. And so you can't breathe. You have to hold your breath. That's why when somebody accidentally falls into a pool and the person doesn't know breath control, the person will die. So if this person is not, if intervention is not given, someone said that you will find ways of what? Of making the person, giving a first aid. So the first aid that he was talking about, he said you should make the person lie down flat. If the person lies down flat, the person is not able to breathe. So if he lies down flat, what will happen? Now the fluid will spread all around the chest. Do you understand? Do you understand? It's like this. having a bottle of water, having a halfway bottle of water, okay? You have water in a bottle and it's halfway. Now, the gaseous exchange occurs at the basis of the hot. It occurs at the lower levels. And now you turn the bottle to lie down. Okay, it means that it is going to cover a larger area of the lower levels. So if you are lying down flat, the fluid spreads to a larger area, and now it makes breathing difficult. So because if you lie down flat, he can breathe using the upper part of the lung. But then if you are lying down flat, the fluid covers a larger area, and so breathing becomes very difficult. So you rather make the patient lie in what? In a cardiac position. You tilt the bed to what? 45 degrees. Some, when they are even worse, they go to 90 degrees. But then mostly it's 45 degrees, so that the patient can what? The fluid can be down, and the patient can breathe with the top part of the lungs. Do you understand?
Can we have the 45 degrees picture just to know how to
Okay,
position
so
the patient?
that is Fowler's position. Let me show you.
So, sir, while you are searching for the picture, I want to ask this question.
Yeah, you can ask your question.
Okay, so what is just now? Can we say a special position for people who has who are asthmatic patients? How they will sleep? They are asthmatic.
People who are what?
Asthmatic.
What has happened to them?
Do you have a special position for them to sleep? Sleeping position.
No.
Okay.
Unless when they have an attack.
Okay.
But if they don't have an attack, they sleep fine. They also have to enjoy life. So this is Fowler's position. So you see, this is at what? This is at what? 45 degrees position. Okay, this is Trendelenburg. Trendelenburg is for edema of the feet and all those ones. The head goes down, and the upper part goes, the lower part goes up. But this is Fowler's position. Fowler's position is what? 45 degrees. So you say we have mid Fowler's, we have high Fowler's. In nursing, we say cardiac position, cardiac bed or cardiac position. So we say mid Fowler's is what? 45 angle. We have low Fowler's 30 angle, high Fowler's 60 to 90 angle. By Fowler's means raising the head end of the bed so that the patient can take in more oxygen. If you are lying down flat, your oxygen level uptake is lower than sitting upright.
Please, can I say something?
Okay, you can come in.
Hello?
Yeah, you
Yeah,
can
there
come
are
in.
two things that I want to. Yeah, there are two things I want to clarify.
You want to?
During the first day training, I want to explain.
Yeah, we are. Oh yes, we are listening. Hello.
It's well too. Two people that answer
Your network is breaking. I can't hear you.
One is for the place. Can you hear me now?
Yeah. It's better now. Yeah, you can talk. Is he talking? Can you hear her?
No, seems like
No,
our
please.
network.
No, please.
Not necessarily you have to put the person down, the CPR, unless the person is unconscious and not breathing.
Dr. Sebunso,
Are you getting me?
you must start
Yes,
it.
sir.
We don't hear you.
We can't hear you unless you start. We can't hear you. We can't hear you at all. So come again. Come again. Oh, her network is not helping. Her network is not helping at all.
Hello, can you hear me now?
No.
No, you hear me now?
Yeah, it's better now.
Yeah,
So,
Hello.
it's better.
yeah,
Can you
yeah,
hear
we
me?
can
It's
hear you.
better.
Hello, me now. Hello.
Yes, we can hear you.
Can you hear me?
Yes, yes,
Yes,
yes,
we
we
can hear
can
you.
hear
We
you.
can hear you. Go
Can you
ahead.
hear me?
Yes, we
Hello.
can hear
Yes,
you now.
Hello.
He has muted himself.
Thank
I'm
you.
Yes,
sure. I'm sure
yes,
he
we
has
Yes,
can
we
muted
hear
can
you.
hear
himself.
you now.
I've not muted
And then we can hear you. We can hear you.
myself, sir. The thing is to teach something and people are not putting it. Putting it into practice is kind of a little bit mistake. When someone is don't do CPR,
Maybe
we
you
put
have
them
to.
into the dorsal position as the lecturer just said. And two, by the asthma, they cannot breathe. It's up. There are some positions they have to sit.
Mr. Eric, your network is
And
not
do
helping at
breathing
all.
exercise.
No, we can't hear you.
Oh,
It's breaking.
please, can you hear me?
No, we
The
can hear
line
you
is
say.
very bad today.
Yeah, so you would hold it for us. Then maybe on our next class, we can discuss that. Okay?
I'm sorry, the lines are bad. I don't know why it's still not clear. I don't know.
Aba, can you hear me? Can you hear me talk? I mean the class. Can you hear me?
Yes, we
Yes,
can hear you.
Yes,
Then it's
yes,
from his,
please, go.
then it's from his network. Then it's from his network. Yeah, so maybe you have to hold it. He wanted to, I mean, enlighten us on some things, but his network is not helping us. So maybe on our next class, maybe he can enlighten us. But for today, he cannot help us. The network is bad. So as part of this is a slide. This is a slide that I got for you online. I mean, I've looked through, and I think that we need to. I was getting some pieces for you on the full blood count. So some key take homes: red blood cell results, platelets, white cells. You are going to read about them. So we say if any of the cell lines are low, anemia, thrombocytopenia, neutropenia, always check a B12 folate, a B12 or folate. If it's acute leukemia, hematologists, biochemical scientists will tell you before you see the results, mature versus immature cells. Okay, this one we will get to know as we continue. So the full blood count is being explained here very, very well. You were asking about the mean corpuscular volume, mean corpuscular hemoglobin. We are going to explain them very, very much here. But then our class is ending now. We are ending at 3, right? You have another class, right?
Yes,
Yeah.
yes, please. It's
So
still open.
for this very slide, I would want you to read through. Okay, this one is about full blood count. It is something that you read through. I wouldn't spend much time on them. I'll just pick some few of them and talk about it. But then, as a slide shows, for instance, platelets. When there is low platelet, we say there is what? Thrombocytopenia. When there is how do you call it? Low platelets. So days or short weeks. When there is what? Sepsis or bleeding, there can be platelets reduction in some days, reduced production, or when there is a reduced production, or when there is a distraction, it can cause thrombocytopenia. That's what the slide means. I mean, for days or weeks, for the reason of thrombocytopenia, that is a reduction in platelet level. It can be that there is consumption from what? From bleeding or what? From sepsis, reduction in production of the platelets. And now on conditions like what? In a state of what? Chemotherapy, there is what? A reduction of production of platelets. And in distraction of platelets, conditions like what? DIC, disseminated intravascular coagulopathy, ITP, HIT, TTP, and MAHA, we will search for them. They are short forms of conditions. Then we have when there is thrombocytopenia for weeks, months, or years. And we are saying that when we are looking at reduced production, it's either there is what? Hematinic deficiency, toxicities to bone marrow, or bone marrow infiltration. And when it comes to consumption level, when there is what? Splenomegaly, the platelets are what? Are being consumed up. So in sepsis, platelets are consumed up, bleeding, platelets are consumed up. And also, that is for days or weeks. That one is for months, years, and we see that your platelets are, I mean, for over years, your platelets are low. Then we say there is what? If it is due to consumption, then we say there is what? Splenomegaly. If it is due to reduced production, then we can say there is what? Hematinic deficiency, a problem with the bone marrow. You see, that is the interpretation. When there is thrombocytosis, that is what? Cytopenia is when there is platelet counts are what? Are low. Thrombocytopenia. Let me show you. Thrombocytopenia. Here, you are going to learn more terms. So, in the medical stuff, you are going to learn more terms, but it is also for your good. Okay, so that when we are talking, you understand. Whenever you get a report or you get a referral from somewhere or anything, you know the medical term, you understand. Yeah. So what is thrombocytopenia? It's a medical condition characterized by low platelet count, which can lead to which can lead to what? Excessive bleeding and bruising. What does platelets do? Platelets contain the what? Clotting factors. It is the platelets that will helps your blood to clot whenever you get what? A cut. So do you see the reason why you have to do a full blood count for your patients? Somebody is going into a surgery and they have not done a platelet for the patient, or they have not done a full blood count or a clotting profile for the patient. What do you mean by that? How would you know if the patient has problem with what? Clotting problems, or if the patient is thrombocytopenic? If someone is thrombocytopenic, or if someone has thrombocytopenia, this person can bleed to death. A small cut, the person will bleed and bleed. Have you to realize that there are some people, something small, it takes a very long time for the bleeding to stop? You understand? We say there is what? Thrombocytopenia. Their platelets are low. Meaning if their platelets are low, their clotting factors are very low. And so these patients can bleed and bleed and bleed. You understand? Then let's look at what? Thrombocytosis. Thrombocytosis. These are medical terms. Now you are learning medical terms. It's a condition characterized by what? Elevated platelet counts in the blood, which can lead to complications such as what? Blood clots, heart attack, or stroke if untreated. So there should be a threshold and a normal range for your platelets. If your platelets are too low, the chances of bleeding is high. And the same way, if your platelets are too high, your chances of your blood clotting up is very high, because the clotting factors are so high. So what will happen is that your blood, instead of your blood flowing normal, they tend to be clotting up. And when they clot up, when blood clot, what happens? Stroke can occur. It can form what we call a thrombus. And this thrombus can what? Can dislodge and go and block a what? Any tiny vessel in your heart or in your brain, and can cause what? A stroke or what? A heart attack. So high platelets is dangerous, low platelets is dangerous. Amado, Madam Amado.
Okay, I am Harry. I'm using different phone. I want to ask a question that what causes someone's blood to be too thick, and then how can it be? What should be done about it so that the clotting level will be normal? Thank you.
So when your clotting factors are high, it can cause your blood to be too thick. When you are dehydrated, it can cause your blood to be too thick, because you are losing what? You are losing volume. You know, the water we take in, we hydrate ourselves. Hydrating yourself also help your blood to flow freely. But when you are dehydrated, your blood becomes viscous. When we say viscosity, do you remember viscosity in school? I mean viscosity in science. The ability of a substance to become thick viscosity. So dehydration makes the blood viscous. If you don't stop me, I'll teach how. Your time is up. Do you have? Is it the next class?
Okay.
Yes, sir. We have a next class. Health communication.
Yes, but I had a pre-appointed meeting before the next class.
Okay, last one. Ingrid. Okay. Should we end it here? Do you have a question, Ingrid? You have a question? Mr. Hammer, Mr. The one using our domains, this one. Are you okay?
No, I didn't have a question, please. I didn't have a question. I was just saying that I do have a meeting now.
Amaduma, are you okay?
Yes, I'm okay. Yes, I'm okay, sir.
All right. So I'll share that slide for you. You read through this particular slide.
Hey.
This particular slide, you're going to read through, and if there's anything with any problem, you can let me know. Okay. Why cell count? You read them. Okay. I'm going to share them to you. So I've explained to you neutropenia, we don't understand it. Just go online, search for it. You understand? Okay then. Have a good day. Enjoy the rest of it.
Thank you.